Great. Now that we have the acid-base box down, let's talk through some disorders that could cause an acidosis from the respiratory side of things. If you had a decrease in alveolar ventilation, that will cause a respiratory acidosis. There are some examples of these, such as if you have a neuromuscular disorder, such as ALS. If you have chronic obstructive pulmonary disease, could also cause a decrease in alveolar ventilation. You can also have decreases in the diffusion capacity of the lung, such as interstitial fibrosis would cause this particular response. Another way you could have a respiratory acidosis if you had a severe ventilation to perfusion mismatch. Severe ventilation to perfusion mismatches sometimes occur in things like chronic bronchitis or very severe asthma or even acute edema. So these are all potential ways you would get a respiratory acidosis. But on something like an acid-base box, what would we be concerned about for this respiratory problem? PaCO2. So if you had a respiratory acidosis, you would be building up carbon dioxide. So you'd have a high PaCO2. And that is what you're looking for a respiratory acidosis. So why am I worried about ventilation when I'm thinking about CO2 values? Well, alveolar ventilation and PaCO2 are inversely related. What do I mean by inversely related? If one goes up, the other's going to go down. If one goes down, the other one's going to go up. So let's take a look at this. If you had hypoventilation, you have a decrease in alveolar ventilation, automatically you have an increase in PaCO2. The opposite also occurs. If you have a hyperventilation, you have an increase in alveolar ventilation, automatically have a decrease in PaCO2. Now, it doesn't matter if this is alveolar CO2 or arterial. So we could use P capital A CO2 or P small a CO2. Either would work fine. There's an inverse relationship. Why is this so handy? Because if you measure someone's PaCO2 with an arterial blood gas, you automatically know what their ventilation status is. If you measured a low PaCO2, you know that their alveolar ventilation rate was high. If you measured a high P small a CO2, you always know that their alveolar ventilation rate was too low. Respiratory acidosis and alkalosis always works in this manner. You notice that I haven't really gone through a lot of respiratory alkalosis problems, right? We went through 3 respiratory acidoses, right? A decrease in alveolar ventilation, a problem with the diffusion capacity, and a severe ventilation and perfusion mismatch. All were respiratory acidosis issues. Respiratory alkalosis, the only thing that happens is you breathe too much. You hyperventilate. That is why you would have a respiratory alkalosis. So you could force yourself to do that by deep breathing. Those large breaths and deep breaths, you could breathe out a lot of your CO2 because you increase alveolar ventilation, PCO2 would drop. Okay. So let's now use a different tool rather than the acid-base box. We'll use an acid-base diagram. Now this has a lot of information on it and is really nice, is allows you to predict what might happen in response to a change in something like ventilation rate. So we have 3 different axes to deal with. We have plasma pH, we have plasma bicarb, and then along these isopleths, which just is a fancy word for this curvilinear line that goes up, PCO2. And this is P small a CO2, or the partial pressure carbon dioxide in the arterial blood. Normally, you have a PaCO2 of 40 millimeters of mercury. You have a plasma pH of 7.4, a bicarb of 24. So that's your normal. The normal is now seen here as a green dot. So the normal condition, PCO2 of 40, plasma pH of 7.4, bicarb level of 24. So that is where our starting point is. If we're going to increase our P small a CO2, that is an increase in carbon dioxide. That happens if you don't ventilate enough. So that is a decrease in alveolar ventilation. We also call that hypercapnia. So in this case, you're traveling from the normal line, which is the green dot, up to the hypercapnia line, which is now at 60 millimeters of mercury. We travel up via a linear line. That linear line is known as the blood buffer line. That blood buffer line was previously defined for us as 25 millimole per unit of pH. This is the buffering ability of whole blood. So things like hemoglobin and other plasma proteins always allow you to travel not linearly, but having a small slope associated with it. The other thing I will point out is that bicarb levels rose slightly, but not a lot, just a little bit. That little increase in bicarb is simply the product of the carbonic anhydrase equation. And I'll explain that a little bit more after we go through the hypocapnic condition. So now let's increase alveolar ventilation. So now we're going to go and breathe off more CO2. In this case, we're going to move now to this blue line, still following the blood buffer line. You increase alveolar ventilation, which blows off more CO2 and causes hypocapnia. You notice in this condition, you have an increase in plasma pH. That's because if you looked at the dot, the blue dot, dropped a vertical line down, you would see that pH increased from 7.4 to very close to 7.6. Now, let's deal with this bicarb issue again. Because when they said the blood buffer line doesn't have bicarb in it, you still might get changes in bicarb. It's a very small change, but there's a small decrease in bicarbonate levels. And that is a hard thing to kind of grapple your head around, because anytime that you have an increase in hydrogen ions, you'll always have a small increase in bicarb. Anytime you have a decrease in hydrogen ions, you'll always have a small decrease in bicarb, because you're following the same equation. What do I mean by the same equation? You take carbon dioxide plus bicarb, you get carbonic acid, and then that product yields a hydrogen ion and a bicarb. So however this formula, if it's traveling in one direction, if you get a change in hydrogen ions, you're always going to get a change associated with its product. Not a large change, but a change. That is why you get a small change in each of those variables as you go from hypo to hypercapnia. In terms of how the body responds to a change in alveolar ventilation. So this is the hyper and hypocapnia that we talked about. How does the body deal with these? You usually deal with a problem by using another system. So if it's a respiratory problem, you try to compensate with the renal system. So let's go through an example for that. If you have a hypercapnic condition, meaning you have a decrease in alveolar ventilation, you're going to go from the normal line up to point number 1. However, to then try to compensate for that, you're going to now travel up the PCO2 line. As you travel up the PCO2 line, this is important, you are not traveling along the blood buffer line anymore. You're traveling up the PCO2 line. This dramatically increases bicarb. Not just a little bit, but a dramatic increase. If you take point number 2 and drop a vertical line down, you will notice that pH is now returning towards normal. So if you started off with a pH of 7.4, maybe move to a pH of maybe 2.5, now you're moving back closer to 7.4 again. The same thing can happen in a time in which you have a low PCO2. So if you now move from normal to 0.1, that is moving down the blood buffer line. How does the body try to compensate for that? You dump bicarb. And you do that at the level of the kidney, and you go from 1 to 2. That is a response, a renal compensation to a respiratory problem. If we use the acid-base box, we can do this also with acidotic conditions. So here we have an arterial blood gas of 7.34, red gnome outside the box. Bicarb below 22, red gnome outside the box. What do we have left? Blue gnome outside the box on the opposite side. By knowing where the gnomes are, I can name this condition. It is metabolic acidosis with respiratory compensation. How do you know that? You always name the condition based upon where the gnomes are. If there are 2 gnomes on one side, that's how you name it. Metabolic acidosis with respiratory compensation. Let's take another example. Let's do another acidosis. So pH from an arterial blood gas, 7.24. Red gnome outside the box. So you know it's an acidosis. Right now, you know it's an acidosis. Now what you're doing is waiting. You're waiting. You're at the edge of your seat. You're thinking, okay, is it going to be metabolic? Is it going to be respiratory? How would you know? The gnome would be outside the box on the same side as the red-hatted gnome. So let's look. Where are we at? The bicarb levels are at 23. Uh-oh, you have a gnome inside the box. Here, you're not sure what to do. Green gnome inside the box. It's going to be hard to name. Red gnome outside the box. Respiratory winner. Whew. This is respiratory acidosis with no metabolic compensation.